Medical school tries to teach you what is already known in medicine. It's not a static body of knowledge. And I was working in the emergency department one day when an old retired Italian car mechanic said to me, "You guys have it easy." And I said, "What do you mean?" And he said to me, "Well, when I was a car mechanic, I had hundreds of different cars that I had to know about, and you only have one human body." And I said, well, that's true. You did. We do have that advantage. But I said, but you have another advantage that we don't have. And he said, "What's that?" And I said, well, you have instruction manuals. So we don't know all about the human body yet. Maybe sometime in the future we will. But right now we have to make a lot of guesses about how the body goes on. And it's really amazing that medicine can function as well as it does. On the next slide. So every day, new discoveries are made, and you need to be able to incorporate these into the foundations given you during training. And you need to keep up with new discoveries so that you can, excuse me, continue to participate, to practice up-to-date medicine. And I tell the residents whom I teach that half of what I tell them now will eventually be proved to be wrong. The problem is I just don't know which half that is. Next slide, please. You'll be given an opportunity to contribute to the body of new discoveries by doing research yourself, perhaps in medical school or perhaps during the rest of your career. And I'd like to introduce you to some aspects of research to consider as you move forward. And I'll focus on the emergency department, but this talk applies to all fields of medicine. So I searched PubMed, and it has a database of US medical journals and major European journals. And to date, there are 26 million publications in 5,639 journals. So the question is, for Bulgaria, how many publications did I find? So is it 1,000 to 999 or A, B, or C? So why don't we take a vote on that?
All right, guys, and in case you don't have the link, I will send it out in the chat as well to put in your web browser to answer these questions.
So Shelley, you have to tell me when we move on.
Yep, so the answers are coming in. Looks like most are saying A at this point.
Okay, well, I think, why don't we move to the next slide? Well, actually,
A's still coming in lead.
All right.
Okay. Some more B's.
Okay, sounds good.
Couple C's.
Okay. All right.
All right.
So it's 10 to the 3rd to 10 to the 4th, 10 to the 4th to 10 to the 5th, or 10 to the 5th to 10 to the 6th publications. All right.
Next slide.
Next slide. So actually, for Bulgaria, I found 40,000. So the answer is B. And actually, there were 9 publications on hot springs in Sofia. So it was interesting to walk around Sofia and see the hot springs and taste the water. So today's objectives, this is sort of an outline of what I'm going to be talking about. So can we move to the next slide, please? So why do research? So it allows me to interact with colleagues and coworkers and doing projects and at my site and elsewhere. It sort of challenges me mentally. I learn new skills that I didn't know before, and exciting to be at the frontier of knowledge. I got a PhD in biochemistry in Berkeley, and I would go into the lab. It was entirely lab science. I'd go into the lab, and at the end of the day, I might have a discovery that I knew the answer to the question, but nobody else in the world did. And maybe other people didn't care, but I found it exciting. And also, it's a change from daily grind and practice. So instead of seeing patients over and over again, which is always interesting, it's a little different change. So it's allowed me to travel to conferences to present abstracts, both nationally and internationally. And when you do that, you're the star of the show because you know more about what you're talking about than anybody else in the world. And you can meet other people at conferences, and you talk about research projects at meetings, and you form collaborations. And the reason I mentioned Richmond is because Peter Richmond was a colleague at Morristown, and now he works in Texas, and we still collaborate on research projects. And an opportunity to work more closely with more experienced colleagues, people that know more than I do, and there are a lot of those folks around, certainly. Next slide, please. So this is an example of at a conference. I'm not exactly sure where it was. I think it was probably in Madagascar, where I was teaching the attendings there and some French medical students. So in the United States, scholarly activity research is a residency requirement for emergency medicine residencies. And I don't know whether that applies to residencies and other specialties in the United States. And I also don't know whether it applies to medical school or residencies or fellowships in Bulgaria. So do you have an opportunity to join a research project during medical school? So I didn't know the answer to this question, so I'm just wondering whether people, okay, well, 2 people have answered. Oh. Okay. All right. Now, the question is a little ambiguous. I wasn't really asking whether you were involved in research project, but rather you have opportunity to join research projects research projects during medical school. So I see that about a quarter say that they have had opportunities to join a research project during medical school.
Yep. All right, I'll move to the next slide. Those are pretty good answers.
Yeah, excellent. So even if you're involved in only one research project in your entire career, doing this will familiarize you with what exactly goes into research. It will help you read papers. It will help you understand that research is not straightforward and help you realize that the limitations of research findings. So, you know, when you read a paper, everything is very clear cut, but when you actually get involved in a research project, you realize things are really not as clear cut as they are proposed. And it helps you appreciate whether a study could have been done better, was done as well as it could have been done. By finding something new, your research may possibly save more lives than you do during your entire career. So Jonas Salk was the developer of the polio vaccine, and Sabin, that was the injected polio vaccine. Sabin and developed the oral polio vaccine, and probably, certainly, by doing that, they saved countless more lives than I have in my entire career.
And this is my fault. This question, sorry, forgot to make this one interactive. My fault.
Okay, well, so the pump in London. So I'm going to talk about the pump in London. And the question was, before I tell you what do you think this might be about, was it the bubonic plague, cholera, the 1918 flu epidemic, or an Aerosmith rock band? And since Shelley unfortunately didn't do it, the answer is it was cholera. So there was a water pump in London and during a cholera epidemic, and it was because of the contaminated water from the pump. So the way they solved the problem was they locked the pump and the pond. So there's perhaps an apocryphal story about a jogger who's jogging around a pond, and he sees he notices there's a guy sitting on a hill watching, and he sees a person in the pond drowning. So the runner strips off his clothing and jumps into the pond and saves him. And then when the saved person gets out of the pond, the runner puts on his jogging clothes and continues running, and he sees a second person drowning in the pond, and he notices that the guy sitting on the hill is just sitting there watching. So he jumps in the water and saves the second person. He runs over to the person sitting on the hill, who happens to be a research scientist. And he says to the research scientist, "How come you're not helping when these people are drowning?" And the research scientist says, "I am helping. I'm trying to figure out who keeps on throwing people into the pond." So sometimes when you do research, you may save more lives than you will, even if you practice for your entire career. Next slide, please. So what you find may not save lives, but it may make other doctors' practice easier. It may make your patients more comfortable and may prevent continuation of useless practices. And we'll talk about that in a little while. Okay, so there are financial awards, less intangible rewards, financial rewards with patents or invitations to lecture. There's prestige. And if you work at a university or other academic institution, research will probably be part of your job. And every encounter, remember, a patient is donating their entire body to help you learn. So every time you see a patient or take care of a patient, the patient is telling you, "Here I am. I'm entirely yours, and I'm here to help you learn." And research is one additional way that you can pay society back for the privilege you have been given and earned. And the symbols at the bottom are Hebrew. It's Tikkun Olam. It means fixing the world. So at least part of my motivation of practicing medicine, doing research, is not only do I want to help my patients and help myself, but I want to make the world a better place. Okay, so I just one slide about PICO. It's patient intervention, comparison, and outcome. So for example, it might be in patients, in children with ear infection, does an intervention, amoxicillin, compared to a placebo, reduce length of time of having the disease. So the reason for formulating the question in that way is it makes it clear what you're looking for when you're either when you're looking for research or when you're doing a research project. So, and when you're doing research, the first thing to do is a literature search to see what has been published on the subject. If there are well-designed studies that have addressed the question, there may be little point repeating the study. However, by definition, research findings need to be reproducible, so that you need to be able to be repeated to be believed. Often studies on important questions are repeated and sometimes different results are found. So there is a PICO question here, and this is something that we addressed in Morristown, where I work. And it's patients with migraine, headache. Does dexamethasone, a steroid, compared to placebo, reduce the recurrent rate of headaches in 24 hours? Okay, and I've written it out there at the bottom, as you can see. So migraine visits represent three out of 1,000 of total ED visits in a recent study. So there are there enough migraine patients to do a trial in one hospital? Our hospital ED volume is 90,000 per year. And what study design should we use? So the next question is, so when you look at that, so you see 3,000 patients a year, 90,000 patients, and there's one migraine patient in 3,000. So how long would it take to accumulate 200 patients? So it's just simple math.
All right, looks like the winner is so far B.
B. Well, actually, it's probably A, because at 90,000 patients with per year, with 3 per 100,000, that's 270 patients a year. So that actually the answer was A.
Okay. Next slide.
Please. So in experimental studies, we evaluate the efficacy of interventions, and the investigator controls allocation. And the premier study design for that would be the prospective randomized double-blind placebo-controlled trial. So this is a concocted example. Supposing we see, I'm working in the emergency department, I happen to notice that I see 5 patients who have poor visual acuity. In the course of talking to them, I find out that none of them eats carrots. So how could we show a relationship between not eating carrots and poor visual acuity? So this is the randomized controlled trial. And this is a cartoon that shows how it might work. We could choose the experimental control trial design and let them eat carrot cake. Okay, so how do we do this? So we start out at the left. Can you see the my cursor, Shelley?
No, we can't see your cursor, but I could do it here. So left.
On the left, the patients in the practice, right? You started with patients in your practice, and you allocate some to a high carrot diet and some to a low carrot diet. And you do that in a randomized manner. And then at some point you measure the visual acuity, and the ones you see whether the ratio of good visual acuity to poor visual acuity is different in the high carrot diet and the low carrot diet. And if they are, then you have shown that eating carrots results in better visual acuity. So that's a pretty simple design. Okay, so let's move on. So the randomized control trial is a double-blind placebo-controlled randomized control trial, is the best study design for therapy questions. So remember we talked about, so what are the two main sources of error in published studies?
Oh, and you can choose 2 on this one, by the way. I set the settings that you have to choose 2.
Okay, well, you've got, although all of them really apply, the answers are random chance and bias. So can we go to the next slide, please? So random chance is the only controller of random chances is study size, and that's where we get the 95% confidence interval, or a p is 0.05. I think some people may be familiar with that. And bias is a systematic deviation from the truth, and we can control bias by the study design. So the randomized control trial is the best designed to reduce bias. And the way it works is that it tries to make sure that the two groups that you're comparing are similar with regard to factors that are known as well as factors that are unknown. But you can never eliminate bias entirely in any trial. So the first thing to do, we talked about, if you're going to do a randomized controlled trial, is to do a literature search. So we did a literature search and found a study that looked at dexamethasone, a steroid, for migraines. And it was published in 1999 in the Canadian Journal of Emergency Medicine. And what they found, they enrolled patients with severe recurrent headache, and 9 of 49 dexamethasone patients, 18% failed treatment, and 22 of 49 placebo patients failed treatment. So the next question is, what is the absolute risk reduction?
And we did the math for you, kind of.
Right. Anybody care to guess or estimate?
There we go, getting some answers.
Okay, and the answer actually is A. Could we go back? Next slide, please. So in the placebo group, there was a 45% chance of a risk of having a bad outcome, and in the treatment group, there was an 18% chance of having a bad outcome. Can we go back 2 slides? All right. So in the dexamethasone group, 18% of patients failed treatment. So the risk of failing treatment was 18%. And in the placebo group, it was 45%. So the risk in each of the groups was 45 and 18%, and the absolute risk reduction is the difference between the two. And the number needed to treat is the inverse of the 27%, which is 4. And what that means is that comparing dexamethasone to placebo, you'd need to treat 4 patients with dexamethasone compared to placebo in order to prevent 1 recurrent headache. And that's the best measure of the effect of a intervention, because you can tell the patient that. You can say you have 1 in 4 chance of getting better by the treatment. Okay. So, excuse me, as you can see, Dr. Allegra is one of the co-authors with myself and Dr. Fieser, who is the principal author of a study that we did on the same question. So we enrolled 173 patients that had complete data. So in the steroid arm, the risk of treatment failure was 22%. The placebo arm was 32%. The difference between the two is 10%. The number needed was 10, but the p-value was 0.21. So 0.21 is not statistically significant. However, we found a meta-analysis that included similar studies. Could you go on to the next slide, Shelley?
Yeah, more than this. There we go. Oh, have you seen a graph like this? Got it. Have you guys seen a graph like the one before that I just showed?
Okay, so about 3 out of 5 have seen one and 2 out of 5 have not. So let's go back to the graph if we could.
No problem. If you'll let me go back.
All right.
There we go.
Okay, so this graph is a representative of a meta-analysis, and it's called a forest plot because the area on the right almost looks like trees in a forest. And if you look at it, there are a total of 1, 2, 3, 4, 5, 6, 1, 2, 3, 4, 5, 6, 7, 8 studies. So this is a summary. This is a meta-analysis, a way of combining the data from 8 studies. So so in the first column, you see the names of the studies. In the second column, there's the second and third column are the events and total number of patients that were given steroids, and then the placebo, the events and total number of patients that were given steroids. The weight has to do with how much each of the studies contributes to the overall average. And on the right-hand side, that vertical line represents no difference between the two. And if the result is to the left of the line, then it means the steroids work better. And if it's to the right of the line, it means the placebo worked better. So for each of the studies, you see a horizontal line with a dot in the middle. And the size of the dot reflects how much the study contributes to the overall evaluation. And the line is the 95% confidence interval. So if the line crosses the vertical line, it means it was not statistically significant. But if it's to the left of the line, it means it favors the steroids. And if it's to the right of the line, it means it favors the placebo. So you can see that the Kelly study actually is slightly to the right of the line. It's the only one that is. And the Innes is the only one that's completely to the left of the line. And it turns out that that sort of rhomboid figure at the bottom under total is the overall estimate of the results of adding all the studies together. And you can see it's to the left of the line, so it favors steroids. And in fact, in this particular case, the number needed to treat was about 10 when you looked at all the things combined. But it didn't cross the line, so it is statistically significant. So they came up with using the meta-analysis, the combination, looking at all the studies together, resulted in the notion that steroids actually do work in terms of treating migraine patients. I guess we can skip the next slide and go to the final one. Okay, so we talked about steroids for migraine, and this is a sort of a very peculiar series of slides about a procedure called mammary artery ligation. So some crazy people in Italy in 1955 reported this procedure, and it involved ligation of the 2 internal mammary arteries in vascular disorders of the myocardium. So if we go to the next slide, please. So this is a cartoon of the aorta, and you can see at the top, the aorta is at the top. There are 2 branches of the aorta, the right and left subclavian artery. And if you look at the top, I'm not sure how clear it is, but you can see there's a branch of the right subclavian artery called the internal thoracic artery or internal mammary artery. So what the notion is that if you ligate those 2 branches, the notion was that since the coronary arteries come off of the aorta very close to right when the aorta exits the heart, that if you ligate the mammary arteries, maybe there would be less flow there and more flow to the coronary arteries. And so people with angina would have relief of their anginal symptoms. So that was sort of the notion of doing that. So the apparent success of this operation caught the attention of the news media. And in a widely read magazine in the United States in 1957, New Surgery for Ailing Hearts, by an American journalist who witnessed the operation performed at the University of Parma. And in fact, one 64-year-old woman suffered from angina so severe that she was confined to bed with pain controlled only by intramuscular injections of meperidine, which is a narcotic that's no longer used. After bilateral ligation, she resumed household chores and was able to walk and climb the 28 steps to her second-floor apartment. The authors noted the clinical improvement in this patient has been almost unbelievable. However, in 4 years later, a decision was made to do a randomized controlled trial. And this was the first study of a surgical procedure where a placebo procedure was used. So, the trial is sort of strangely described. It's really before a time when informed consent was necessarily gotten. And a reasonable optimistic attitude on the physician's part was maintained. The subjects were informed of the fact that this procedure had not been proved to be of value, and yet many were aware of the enthusiastic report published in the Reader's Digest. And interestingly enough, the patients were told only that they were participating in an evaluation of this operation. They weren't informed of the double-blind nature of the study. And at the time of the operation, which was performed under a local anesthesia, the surgeon was handed a randomly selected envelope, which contained a card instructing him whether or not to ligate the internal mammary arteries after they had been isolated. So some people got the mammary arteries ligated, and some people were opened up, and the mammary arteries were found, and then the patients were closed up without anything being done to the mammary arteries. And the physicians following the patients postoperatively were not informed what was actually done in the operating room until the postoperative evaluations were completed. So the evaluators of the outcome were blinded to what actually happened during the surgery. So this paper in 1959 showed that all patients improved. Exercise tolerance increased, anginal symptoms decreased, and nitroglycerin use decreased, and there was no difference between intervention and placebo. So in spite of the fact that the previous study that was just a case series had been done, in this particular case, when the randomized controlled trial was actually done, there was no difference between intervention and placebo. So the degree of improvement in some cases was extraordinary. One patient who had been able to work because of his heart disease was also almost immediately rehabilitated and was able to return to his former occupation. He reported 100% improvement at 6 months and a 75% improvement after 1 year. He was in the group whose arteries were not ligated. So the likely explanation was that it could be a placebo effect or possibly during the procedure, the nerves reporting the anginal symptoms of the brain were severed. And so people no longer felt the anginal symptoms, even though they were actually having some myocardial decreased flow of blood to the heart. So half the participants got a sham procedure. Was this trial ethical? So what do you think? So half the patients they were just opened up, and people looked around, and then they closed them up again. So it looks like we're getting close to being evenly divided. All right, and more people said it was unethical than ethical. Interesting. So to some extent, it was unethical because the patients really didn't get complete informed consent. But had they gotten informed consent, I think it would have been entirely ethical. But just consider that had they not done the randomized control trial, hundreds and perhaps thousands, perhaps tens of thousands or hundreds of thousands of patients would have undergone this procedure when it had actually no benefit. So in some way, when you do randomized control trials, what you're doing is you're saying, we're going to put you at some risk, and you're going to understand the risk, and we'll tell you what the risk is. But we're doing it so that for all the patients afterwards, they will or will not. We can show that they have or have not benefited from this procedure. So does it really work? So some folks in 2017 did an open label clinical trial in 50 patients with coronary artery disease. It was a before-after study. So they looked at patients before the procedure and after the procedure. And the way they ligated the artery was not through a surgery, but rather they had internal mammary artery occlusion device, which was accessed vascularly. And they showed that you increased right coronary artery flow almost twofold, although no change to left coronary artery, and reduces myocardial ischemia during a 1 minute ostial right coronary artery balloon occlusion. So it's sort of interesting that it has come full circle. So I'm not sure that anybody is doing that procedure, but certainly it's a possibility. So we talked about the randomized controlled trial that we did. So I wanted to just take how long does it take on average from time you decide to design an RCT to publication? So on average, there's nothing cut and dried about this, but I just want you consider this, because when you're going to design a randomized control trial, you need to decide how long it's going to take you. If it's going to take you your entire career, it probably isn't worth it. From your own, you may not benefit. So actually the answer is 4 years. So it takes about 4 years from and that was true for the dexamethasone study and some other randomized controlled trials that we've done in the emergency department. All right. So I don't know whether I don't know whether people are using intravenous ketorolac or Toradol in renal colic patients. So does it provide effective pain relief? So that was the clinical question. So in patients, in patients with renal colic, does ketorolac compared to placebo improve pain? So what study was design should be used? Okay. So you would think that the RCT would be, and I think that everybody agreed on that, but let's go on and see what we actually did. It wasn't me, it was Dr. Allegra and his colleagues. So it's Larson, Miller, and Allegra, published in 1993, and the use of intravenous ketorolac for the treatment of renal colic in the emergency department. Let's move on. So the objective of this study was to determine the effectiveness of intravenous ketorolac as an analgesic in the treatment of renal colic in the convenience sample at 3 suburban community hospital emergency departments. So they administered ketorolac 30 milligrams IV during a 1-minute period, and then they looked at the pain scores on a scale of 0 to 10 at 0, 5, 10, 20, 30, and 60 minutes, and also looked at adverse side effects, and they included a total of 25 patients. Doesn't sound like a lot. So this is the result that they found. So this is a graph. On the x-axis is time from 0 to 60 minutes. On the y-axis is pain scores. On its pain scores on a scale of 1 to 10. So as you can see at the beginning, people had a lot of pain, and by 60 minutes they had no pain, and by 30 minutes it was down by 90%. So there were no adverse side effects observed in any patients, and this was a small observational study, but the results are very compelling that ketorolac is very effective in renal colic. And the journal editors agree that a comparison group was not needed. So it was not an RCT, it was a case series. So even though the RCT is the gold standard or the criterion standard for therapy interventions, you can sometimes show a result even though you haven't done an RCT. So you need to be married only to the RCT when you're a randomized controlled trial when you're doing research. So I'm going to talk about case control studies. This is a different study design. It's useful in rare diseases. So what you do is collect all the cases and go back and see what risk factors were associated with the cases. And then you can obtain a control group without the disease and look at the incidence of the risk factors in there. And you compare the prevalence of risk factors in the cases and controls. And the Center for Disease Control in the United States uses this method to investigate outbreaks. For example, they develop questionnaires for diarrheal outbreaks, and they find out where did you eat and what did you eat and so on. So if they show that folks ate at a certain restaurant, had diarrheal disease, then they ask folks that ate at a different restaurant where they had diarrheal disease. And if there's a difference, then it sort of suggests that that eating at a particular restaurant was involved in, there was an association between eating there and diarrheal diseases. So we'll go back to the carrots and the poor visual acuity. So you find 100 patients with poor visual acuity, and you find another 100 patients with good visual acuity, and you ask them about their dietary habits, particularly with regard to carrot intake. So again, this is a cartoon. So you begin at the right-hand side, and you have cases. The cases are patients with poor acuity, and then you choose a group of controls with good visual acuity, and then you go back and you ask them, each of the groups, whether they ate many carrots or few carrots, and then you compare the ratios on the left-hand side. And if there's a difference in the ratios, then you come to the conclusion that eating carrots has a salutary benefit for visual acuity. So this was a case-controlled study to demonstrate an association between the use of diethylstilbestrol during pregnancy and vaginal carcinomas years later in their daughters. And it was published in 1971. And keep that in mind. So Herbst and his colleagues noticed an unusual cluster of vaginal cancer cases in young women born between 1946 and 1951. So this was something, he just noticed that there were a bunch of women. And he looked at all possible factors associated with the disease. And the one common factor that was diethylstilbestrol, DES, used by their mothers while they were pregnant with these young women. Now, DES is a synthetic estrogen. It was prescribed to pregnant women between 1940 and 1971 to prevent miscarriage, premature labor, and other pregnancy complications. And they had these eight young women, and they chose 30 controls born around the same time who did not have the disease as comparison. So this was their finding. So on the top is whether or not they had vaginal adenocarcinoma or the controls. And on the left was whether or not they identified DES use during pregnancy. And you can see 7 out of 8 of the women that had vaginal adenocarcinoma were found, it was found that their mothers had used DES during their pregnancy and none of the controls. And so the difference was a p-value of was a very small p-value. So it's almost certainly an association could be strongly suggested. So the case control study is useful in rare diseases. In Herbst's case, it was able to show a result with only 38 patients. And this study design was the only practical way to do it. You couldn't do an RCT. First of all, it would be unethical. And secondly, it would take more than 20 years to do. So just by this case control study, they were able to show that pretty conclusively that DES was involved with this carcinoma. And okay, so now we're going to talk about observational studies. By the way, I do have a lot to talk about, but we'll certainly stop, I believe, at 5:02 in order to give you a break. So I may not finish the entire presentation, but that's okay. So observational studies are easier to do because there's no randomization, can be retrospective or prospective. And retrospective data studies are faster to do since you already have the data. And it actually eliminates some bias because collectors of the data were not aware of the study when the data was collected because the study had not been thought of yet. And most studies that we do at Morristown are observational, although we have done a number of randomized controlled trials at Morristown. So in cohort studies, you take a population of cohort, you make simultaneous assessments of outcomes and potential predictors. It is a slice of time design. So what has their carrot consumption been? So again, this is the cartoon. So you begin with patients in your practice, and then you measure the visual acuities, and you at the same time ask them, have you had been eating a lot of carrots or not very many carrots? And also called prevalence studies or cross-sectional studies, the population basis makes it possible to estimate disease frequency within a group. In the case control study, you can't really estimate the population, the disease frequency within any group. So what are the advantages of the RCTs over observational studies? So which do you think? So we have one vote for reduces bias. Nobody else wants to vote?
There it is.
Okay.
A little delayed.
All right. All right. It's a horse race. All of the above is gaining slowly, but we'll have to see. All right, let's move on to the next. So the answer is D. So cohort studies have economy and eliminate some bias, as I mentioned. RCTs are better planning and control. you can ascribe cause and effect. You can only ascribe association with cohort studies, and reduces bias, which is systematic deviation from the truth. So the disadvantages of cohort studies are difficulties in retrieving information from the past, finding proper comparison groups, and you may need long follow-up time to monitor for development of disease in the Framingham heart studies in the United States. Framingham is a town in eastern Massachusetts. They followed patients for many years, and you cannot ascribe cause and effect, but RCTs require ongoing diligence, take time to collect data, and usually requires more work to comply with our institutional review board requirements. So I'm just going to talk about some other Morristown studies, so pay attention. This was a study, observational study. Its diagnosis of carotid and vertebral artery dissections by emergency physicians is rare. And we had a database of over 6 million ED visits, and we had that number of carotid artery dissections and vertebral artery dissections. So it was one carotid artery dissection for every of either one for every 5,000 or 50,000 or 60,000 ED visits. So that means that an ED physician seeing 3,000 to 4,000 patients a year would diagnose one each every 13 to 18 years, or one dissection every 16 to 21 years. Okay, and we had another unusual diagnosis, venous thrombosis, sinus venous thrombosis. So it occurs, could we just go back, Shelley, sorry. It occurs when a blood clot forms in the brain's venous sinuses, and it presents with neurologic deficits and headache. So we did the same kind of study, and we see that an ED physician, so it's seeing 3,000 to 4,000 patients a year would be unlikely to diagnose a cerebral venous thrombosis in their career. And this is important because at least in the United States, there are situations where diagnoses are missed and physicians are blamed for making the diagnosis. But our studies show that it's really very difficult to make the diagnosis because the diseases occur so infrequently, and some of the symptoms they have mimic other more common diseases. So were you paying attention? So which do you think? So is the carotid artery dissection is more common, as common, or less common than cerebral venous sinus thrombosis? Does anybody remember what we said? Okay, well, actually, the answer is A, because we said that a carotid artery dissection, you might see it every number of 10 to 15 years, and you would almost never see a cerebral venous sinus thrombosis. Okay, so a 30-year-old man was lifting a heavy object with his shoulder in an awkward position when he felt sudden severe shoulder pain. His exam shows an obvious dislocation. Should you do a pre-reduction X-ray? So that was what study design would you use to look at this? Any suggestions? Nobody wants to venture a guess? Okay. All right. So in this particular case, you're correct. It's a case series. So why don't we look at the actual study? So some would advocate against using routine use of pre-reduction X-rays for shoulder dislocations. Our objective was to, in a large database, the percent of dislocations that also had fractures as a function of age, to determine whether there is some decades of life with a sufficiently low risk of fracture, so you didn't need pre-reduction X-rays. So we had a total in the database of about over 5 million visits. There were about 7,000 patients with dislocations. About a small percentage, 6.5%, had fractures. And let's go to the next slide, please. So this is a graph, and on the ordinate is, or the y-axis was the percentage with fractures, and on the x-axis was the decade of life. So the first decade of life is 0 to 10 years of age, second is 10 to 20, and so on. You can see that in the second and third decades of life, so between the ages of 10 and 30, the percentage of fracture was extremely low. It was about 1%. So this was a case series. So if we omitted the pre-reduction x-rays for patients in the second and third decades of life, we reduced the number of pre-reduction x-rays by 40%. So we're getting close to the end, and I may stop after we go through this. How useful are the elements of the history and physical exam in making the diagnosis? So what is the best type of study design for these? All right, let's move on. So it's cohort study. I think you're probably correct. So before we look at this, it would be useful to look at likelihood ratios. So the definition of a likelihood ratio is the probability of finding a result in patients with disease divided by the probability of finding the same result in patients without disease. And it's related to sensitivity and specificity with those formulas. However, unlike sensitivity and specificity, they can be applied to individual patients. So the way you use it is you take the likelihood ratio and multiply it by the pretest odds, and you get post-test odds. And odds are probability over 1 minus probability. So if you have, if you are in a, or if you're betting on a horse race and your horse has a 50% chance of winning, then the odds are 1 to 1. So it's 50% winning divided by 50% losing. So it's 1 to 1. So the Fagan nomogram is the easiest way of using likelihood ratios to go from pretest probability to post-test probability. And this is an example of a Fagan nomogram. So on the left is the pretest probability going from 0.1% to 99%. And the right is the post-test probability going again from 0.1% to 99%. And the likelihood ratio is in the middle. So for example, in the upper line, you started with a pretest probability of 40 and the likelihood ratio is 20. So the post-test probability is 94%. And in the bottom, you can see that if the likelihood ratio is 0.2, then the post-test probability is about 8%. So if the likelihood ratio is 1, then the test does not change probability. If it's greater than 1, then the test increases probability. And if the likelihood ratio is less than 1, then the test decreases probability. In general, in order to make a significant change in probability, the likelihood ratio has to be greater than 5 or less than 0.2. So do you remember the definition of a likelihood ratio? I told you what it was. If you remember, which of those do you think it was?
This may take a little time for everyone to read,
Okay.
but the poll is open.
If you don't want to guess, that's fine. The likelihood ratio is a interesting concept that's sometimes hard to grasp, but it's very useful, and you'll see the reason why in a minute. So, okay, so you're correct. It's the probability of finding a result in patients with disease divided by the probability of finding the same result in patients without disease. All right. So, so the Rational Clinical Exam series is a series in the Journal of the American Medical Association. It uses elements of the history and physical simple tests as diagnostic tools. For example, they have a paper called "Does This Child Have Appendicitis?" and looks at different elements of the history and physical exam to make it more likely or less likely that the patient in front of you has appendicitis. Does this patient have septic arthritis? It aggregates information from other studies. And the most useful result to look at is the likelihood ratio. So the question that they posed is, this patient have cardiac syncope? So you're in you're working and you see a patient that has a syncopal episode, and the question that comes to your mind is this because of some kind of heart problem, or is it something else, like a vasovagal syncope, or did they did they have internal bleeding, or were they dehydrated? So we move on. So this is a table, characteristic of patients and studies with review of accuracy of the clinical exam in detecting cardiac syncope. So you can see the finding are the patient demographics, and you can see the likelihood ratios, and you can see that, for example, atrial fibrillation or atrial flutter has a likelihood ratio of 7.3. So if the patient has a history of atrial fibrillation or flutter, then it makes it more likely. Again, the likelihood ratio is greater than 5. On the other hand, if you go down, you can see warm place or pain or medical procedure, then the likelihood ratio is small. It's less than 0.2. And that means that if they had the syncopal episode in a warm place, or they had pain or medical procedure, or even if they were sitting on the toilet after using the toilet, it makes it less likely that the syncope was cardiac. And you can use that in terms of evaluating patients when you see them. And here again, there's if you look at the left-hand column, comparing seizure with syncope. So if they wet their bed, it makes it more likely it's a seizure. The likelihood ratio is 6.7 versus if they syncope, if they didn't wet their bed, then it makes it more likely that it's syncope. Okay, so I think that I only have a couple of minutes left. So I just let me just introduce COVID-19. So COVID-19 arrived in Morristown at the beginning of March 2020, and the first cases in Bulgaria were about the same time, as you can see. I think that we'll stop there. I had a bunch of slides about COVID-19 and syncope, but I want to thank you very much for your attention to my presentation. I hope that at least it may have piqued your interest in getting involved in research projects. I have been doing research. I started out as I mentioned, a PhD in biochemistry, and I enjoyed doing research when I was a PhD. It was exciting for me, and I find it exciting to do research in the emergency department, although it's not pure science as it was in Berkeley when I was a graduate student. Nonetheless, it's exciting to be able to do research, both fulfilling a natural curiosity and also hopefully contributing to the medical body of knowledge that may assist physicians in the future. So thank you very much for your attention, and I hope you enjoy the rest of your day at this conference.
Awesome. Thank you, Barney. Hold on. Do you need to do research to get a job? That's your question for the end of your lecture. They said, do you need to do research to get a job?
Well, it really depends, because often if you have something special to in the United States, if you have something special to offer, often it helps you get a job in places where there's a lot of competition for jobs. So that's the reason why people do research. It's also the reason why people in the United States do fellowships, so they become ultrasound proficient or specialize in pediatric emergency medicine and so on.
And a big thing is that Barney talked about in the beginning, in emergency medicine residency, research is a requirement. So I know some people are asking about that. It looks like a lot of students are asking, as a medical student, how would you approach a professor to ask to be part of research?
Okay, I think that's a good question, and I don't know exactly how it works in Bulgaria. In the United States, we do have medical students who have rotated through our emergency department and do research. We had a medical student who actually from Great Britain, who came over and spent the summer with us and wrote a paper, a research paper, which is remarkable. It's the only paper that I ever submitted where it was accepted as written by the editors of the journal. And so, and now she's a family doctor who works in northern New Jersey. It's certainly possible in the United States for medical students to get involved in research. I just don't know what the situation is exactly in Bulgaria.
And how is getting involved in research being affected by COVID? How could they still get involved despite COVID? Okay,
well, that's a good question. So a lot of the research we've done recently is on COVID, particularly we're doing some research that's observational studies where we're looking at, for example, what happens in the pre-hospital situation where people are pronounced dead. Has there been an increase in pre-hospital pronouncements of death during the COVID epidemic? And in fact, we found that. So if there's excuse me, databases that are available to you, you can ask questions just like we did with some of the studies that I mentioned to you.
Awesome. And yes, another question was, are med students actually helpful? Yes, they're very helpful. As Barney said, they did have one of their students write a paper and get accepted. So I hope this sparked your interest in research. Just so we're not totally late on time, we're going to just have a 3-minute break as we get ready for our next lecture. Okay, so be back 1 minute after the hour.
And thanks again for your attention.
Awesome. Thank you, Barney.